Well, hello, everybody. My name is Garrett Schmidt, and I'm the managing editor for VBC Exhibit Hall. And I would like to welcome you all to today's live webinar hosted by mPulse Mobile, and it is titled Unnecessary and Avoidable Solutions for, Unnecessary and Avoidable, Solutions for Emergency Department Diversion. That's an important caveat. This is a really important topic and something that I know is a big part of value-based care and managing a population successfully and effectively. So very excited to hear from our speakers today, who I will introduce in just a moment. A couple of items of note before we get started. This is a traditional webinar format, so everyone has joined today in listen-only mode, so you don't need to worry about muting your microphone or your camera or anything like that. But we do want to hear from you, and we're going to have some time for some Q&A toward the end. And so at any time during the presentation, you can ask a question using your control module. There's a little place for questions, which is different than the chat. So be careful with that one. But go ahead and submit your question at any point, and then we're going to get to as many as we can during the allotted time today. If we don't get to yours for some reason, don't worry, someone will reach out via email afterwards and make sure to answer your question. Finally, today's session is being recorded. So what's going to happen is when we're done, say about maybe an hour afterwards, you'll receive an email from one of us, and it will have a link to the recording as well as to where you can download the slides. And it'll be a shareable link that you can hopefully either rewatch, share with colleagues and friends, and forward on. I hope that you do. And we're just glad that you're here with us today. Without further ado, wanted to quickly introduce our speakers today. First of all, we have Ms. Wendy Cutting, and she is the VP of Healthcare Engagement Solutions. And then we have Mr. Aram Kodagian, and he is the Director of Value-Based Care Solutions and they're both with mPulse Mobile. And Aram, I hope I didn't butcher your last name.
It's pretty close. I mean, you got really close, so I give you credit for that. Most people.
Awesome. Well, it's good to have you guys. I'm going to go ahead and turn it over to you now, and I'll see you during Q&A.
Awesome. Thanks, Garrett. Appreciate it. So, as Garrett mentioned, my name is Aram Kodigyan. I've actually been at mPulse for almost 5 years now. Live in Los Angeles, California. So I have a bachelor's degree in economics and currently am an MBA candidate. At mPulse Mobile, what I do is entirely focus on really the provider side of value-based care solutions, working with ACOs, MSOs, CINs, IPAs, any of those things to improve patient engagement and get different populations, whether it's Medicaid, Medicare, commercial, to take the next best action for their health. So they can remain healthy and really prevent further health issues. And of course, healthcare organizations, they benefit from that, right? By keeping total cost of care down and then closing gaps in care. I'll pass it over to you, Wendy, to speak a little bit about yourself.
Great, thanks, Aram. First of all, good morning and afternoon. Thank you all for joining this conversation, which is very important, I feel, across the US in total. So my name again is Wendy Cutting. I am the Vice President of Product and Product Design here at mPulse. I've been with the organization for 6 months, and it's been a fantastic ride. It's been so nice to move to what I call the side of the fence where we're engaging patients and our members before care occurs. And just a little background on me, I've spent 8 years in the healthcare space, most recently at United, working in the Optum and United healthcare space, where I was focused on leading the member digital portal and mobile apps for our total member population across all lines of business. I also spent some time at Blue Cross Blue Shield of Minnesota, and I spent about half of my career in the retail space working for Target and Best Buy, where I really cut my teeth into product and serving customers and bringing the concept of meeting the customer or consumer where they are on their journey with whatever it is we've got in front of them. My responsibilities at United really included the digital products and the journeys for all lines of businesses, where we were reducing cost of care, moving people closer to the payer portal so that they could ensure they were seeing the right doctors in network, ensuring they understood what their claims were, knowing their benefits, and really getting members engaged, where we saw a big shift in total cost of care decrease for those members that actually engaged in their healthcare plan. I have a passion for healthcare. I have a passion for helping the consumer from the end-to-end experience and driving the outcomes that we're looking for from a business perspective to get that behavior change where people are shifting and taking action on the healthcare that they have in front of them more from a proactive perspective than anything else. And I am located in the Minneapolis area, not too far from the United headquarters, actually, myself. So I'll hand it over to you.
Thanks, Wendy.
Thank
So
you.
I'm going to set kind of the stage, the agenda of what we're going to do, then I'll pass it back to Wendy. Over here, you're kind of seeing what we're going to first start off with, which is the current state of the emergency department, then kind of understanding why patients are seeking ED over other potential options, whether it's PCP or urgent care, for example. Then avoidable versus unnecessary. What are the differences over here? The solutions that we have for emergency department diversion, how we address that issue, cost savings, and then of course questions that you all may have will have answers for you at the end of it. So Wendy, take it away. There you go.
Fantastic. So this first bit of information is really centered around data and what it looks like across the landscape of the United States. So this information really tells us where, from a need state, where people are going to ER and the actions that they're taking. As we know, emergency room department visits are necessary some of the time. However, across the US, we see a large amount of people that tend to seek ED or emergency room care when they might not need to. And so that's where we're going to spend some time talking about avoidable and other options that we could potentially provide for our patients so that they seek care outside of ED. And as payers and plans know well, there is an excess of claims paid out for services which could have likely been handled elsewhere. And this is something that we look to help support. As we think about the consumer, educating and directing is critical. And by doing that repeatedly and building that conscious behavioral science piece into our membership population, that's where we see a shift. And at the end of the day, we use data to see how our return on these programs work to shift people to non-emergent care. And we can go ahead to the next data slide. And this slide specifically gets deep into where people are spending time in the ER. If you look to the right, I know it's a little bit busy, but I'll just hit on the top points that I think matter most. When we look at the non-mental health conditions, we see people seeking care for abdominal and other digestive conditions that could easily be explained to a patient or a member in an education moment. So depending on the type of condition, we can be in front of those members. And if we know that the members have conditions, we should be able to tackle those issues prior to members seeking ED care. The second one being respiratory. One of the things that when I see that, the first thing that comes to my mind is this is something that we know, depending on the seasonality, it's something that we always have foresight on. And we have a plethora of vaccines out there that greatly reduce the need to go to ER. So education and information that allows our members and the population, total population, be it adults or children, to make the best informed decisions possible. When we look at the mental health space, it gets a little more challenging, and we're going to cover some more information on this topic. We know that in the past couple of years, it's been a challenge from a have accessibility and having resources available. When we look at alcohol, anxiety, and depression, those areas we have resource constraints, but we do have potential options that come from our payers. We have content, we have information that we can help steer people to the right professionals so that they stay out of the ER and get the help they need and have confidence knowing that they have somebody to turn to. When we think about how we can change and shift the landscape, I believe everybody has a play in this space to look at where people are going, why they're going, and start to carve out help for our patients. One of the things I think that I love seeing last year, I think it was last year, we stood up the National Suicide and Crisis Hotline. There was a number shortened to 988 for people that struggle with mental health. Just that simple change in making access to care for people that need it, it's those little steps that make it reduce one step or a massive amount of people going into the emergency rooms. We do know that emergency deflection is more, or emergency department access is more convenient. We also know, and we've seen, that proximity to EDs across the US is sometimes easier to come by than finding a primary clinic. I, as a daughter of a 70-year-old mother, just recently experienced a scenario myself where we found ourselves in an emergency room while traveling to visit my sister in Florida. And oddly enough, my mom fit the category of abdominal pain. She herself worked for Blue Cross Blue Shield for 35 years, and here I am presenting on this information. And we found ourselves in the ED where it ended up taking her entire day out of the trip. There's, waiting concerns around catching other illnesses, a lot of things that coincided with the decision we made at that point in time, which was really kind of off the cuff to go to the ER. We had a conversation post-care around what could we have done different to prepare ourselves for that trip. In hindsight, traveling with an older person, now I know, and sometimes it takes one to shift the mindset, but preparing for where we're going to be, what doctors could my mother see, where could we have gone that would have saved time and actually money from the system. And so I'm sure everybody has an example of a time at which they've had to attend an ER visit and could have gone somewhere else. But the more we can educate, I think the stronger our citizens become. So my recommendation always is to get the education. 8 times is the charm. They say it sticks. So we can never overemphasize how important it is to understand where to seek care for the conditions we have or might have in the future. All right. And this information right here I mentioned 50% of the population. So if you look at to the right, the data that we see here, 50% of the population that seeks care has it probably at one point in time gone to the ER. And so this is the data that I know that we at mPulse look at to try to be part of the big scheme of things, decrease that number. So ultimately, as payers, providers, everybody on the call, it is a business opportunity, I believe, for most of us to reduce our total cost of care. The question is, how do we do it, and how do we triangulate what we do back to the decrease in claims in these areas? There's, the social isolation piece that's specifically stated in here goes back to the slide I was just talking about, which is one that's a challenge from a behavioral perspective, but from the behavioral to behavioral conditions that we've got, there are definitely ways that we can help our members preemptively find the care that they need. I'm going to move into a poll. This poll is curious to understand what people think or what they've done to implement to support their patients or their members from attending an ED event. Go ahead.
Okay, I'm showing the poll right now. Are you guys able to see that?
Yes.
Okay, so we're giving people some a little bit of time to answer. Let me get answers rolling in. We'll give it about another 10 seconds or so. You want to select all that apply in this case. And we'll show the results so you be able to get a feel also for your fellow listeners and attendees, where they're at. The answers are still rolling in, so give it a little bit more time here. Okay, I think that's about it. We're going to go ahead and close it down in 5, 4, 3, 2, and 1. Close, and then I'm going to share the results. Are you guys able to see the results?
Yes.
Coming up. And yes. Yeah,
Okay.
we're able to. Yeah, and it's interesting, again, I think, Wendy, we were talking about this probably yesterday when we were kind of going through this information about telehealth, and I had mentioned, a big payer provider out here on my side that had mentioned that they don't even try telehealth really, and they want to actually see them to get that PCP connection in instead of doing telehealth. And of course, it was with a Medicaid population, and a good amount of them were homeless or had mental health issues. So I think again, it probably depends from region, but I know that you had some insight on really the payer side of things as well.
Yeah, on the payer side, coming from the experience I had, the notion was telehealth is a very good first stop to avoid ED because it provides more context and information for those folks on the side of the provider to help steer those members to the right care and care path. So it is definitely something that we use to promote the steerage of ER visits.
Yeah,
this is very yeah, it's great feedback. Thank you.
Good feedback. Thanks, everyone. Let me move on to the next one real quick. There we go.
All right. So touching on a little bit at the beginning of the call, avoidable versus unnecessary. What is the difference? I think the simple answer is anything that we can do to help a patient understand and provide access to immediate care needs is the answer. ED visits are typically where people go in crisis mode, as I mentioned earlier. Even if a doctor might not see the condition to be even if we might not see the condition to be life-threatening, in the eyes of a patient at that moment in time, that's maybe how they feel, and therefore they choose the emergency room as their way to seek that care. Conversations proactively with doctors or nurses or care based to basically what we just saw, conversations that happen within the provider space and payer space allows us to have those conversations with people so they feel more comfortable and confident in making decisions. If we look at claims data for our members, we might have a really good picture of how we need to uniquely reach each person with more information and education specific to their conditions. Outreach can happen in several ways, and by using all channels available, the likelihood to resonate with a patient is more prevalent. If we think about a patient or a member with a condition, we can clearly execute a path to care that completely takes ED out of the equation. However, in a time with information overload and people simply living busy lives, it is a challenge to reach people. We have to use the data to inform how we communicate and deliver the yields yields the greatest results. And so what that means is developing programs and outreach that we continue to enhance to see what that data informs us and how people are taking. So it could be as simple as when we send a message to a member based on a specific persona type, where they work, where they live, could matter significantly in how they engage with their healthcare plan. All right. So some of the factors that we use here at mPulse in the creation of our programs surround several things, one of them being health equity. We work hard on ensuring that the content that we deliver is of the right reading level. We're focused on the personas. Who are we targeting? Again, as I mentioned, where do they live? What do they look like? How do they interact with their current healthcare plan? What do they have accessible to them? We take that into account when we're writing messages and we're creating information for all of our lines of business, whether it be Medicaid, ACO, Medicare, commercial. Everybody has different goals to some level. At the end of the day, we're talking ER diversion, which is one, I call it theme. The way that we get there is all dependent on the person that we're targeting. I think most of our clients have English and Spanish programs, which is normal, but we also have where we need to support other languages. There might be regions of our country where we have a population that might be outside of the English and Spanish, and same with the reading level. We need to know who we're targeting and make sure that the communication is sound and that they feel they have the tools they need to be able to take the actions they can to support the advances of their own healthcare. And we move into behavioral science, which is a really unique tactic that we use here. Behavioral science is, I call it an art and a science. So the art of it is understanding people, the science of it is what they do. And so as we look at and we do the anthropologies, we speak with people and really truly understand what they look like. We use 3 tactics to support those folks. We have what we call a storytelling effect. We're using different methods to communicate the message, not just a long email or text. We do this through tactics which we call photo novellas, animated videos, and other informational help for patients to understand and retain information. We also have what's called the spark effect, and that's making health action easy. We want to make sure that that our members or our patients understand and don't feel like stupid as compared to their counterparts or people in the industry themselves. We want to make sure that we provide links that are clear and actions that they can take in, whether it be scheduling, finding a doctor. We want to make it easy for them to take that next best action. And then lastly, we have what's called loss aversion. Loss aversion is a program which we will be seeing shortly in a streaming video that Aram is going to be playing. But essentially, it covers, it takes, when you think about ER diversion, there's 2 pieces to it. There's the cost and there's the time. For some members that have a cost associated, they have a cost and a time issue. So what is it going to cost me out of pocket? And then how much time is it taking me out of my day? In the instance I shared of my mom, where it's not necessarily a cost play, it's a time play, since I just spent the whole entire day in the ER when I could have maybe gotten to the urgent care center. And then we've got the educational piece, which I believe, and in my time at United and at Blue Cross Blue Shield, was the #1 most simple way to reach people and be clear. And it was the most cost effective. So at the end of the day, if we built better content that's really made it clear why a member or a patient should seek care for a specific condition, we saw that data tenfold as it related to their claims. Understanding your benefits, knowing what you're covered for, understanding conditions and when to be seen. We at mPulse use tactics like I was mentioning earlier, videos in specific created animated snippets and clips that resonate with the specific population that we're trying to reach. And in this video, which we'll be seeing next here shortly, Aram will show the difference between when we go to an urgency room versus an urgent care center. The journey. So the patient journey. This journey outlines what could potentially be an example of how we avoid ER visits in the future. So this is an example of how we outline our journey flow. Top left side is a gentleman, think of a persona or somebody that is seeking specific care. In this instance, they have mental health issues. And so this gentleman has social isolation, whatever it may be, and he seeks an ER visit. When he seeks the ER visit, he's given potentially a diagnosis and medication to help with that specific condition. This gentleman is now entered into the system. So if we think at the payer level, he has now had a claim. He's now part of the system around specifically this mental health, where next steps would be getting them into programs where we can start to outreach to them. So identifying challenges, what does this person have or need from their healthcare system so that they can stay on track to make the best decisions for their health and feel better. So we start with identifying their challenges. Then we move through to reaching out to them. So they've opted into the program. We reach out to them consistently with the education information, with the right data, and make them aware of what they have available to them. And then upon completion of this specific program, when they've entered, we want to make sure that we continue them through the life cycle, which means moving them potentially into medication refill reminders. It may be ongoing appointments with their psychologist, whatever that may be. The goal for us in this instance is to guide that member through the entire life of the journey that they need from the healthcare provider. Digging a little deeper, how do we do that? So we've got what's called a two-way SMS. Those of you familiar with SMS, whether it be in the retail space, you ordered something, or in the healthcare space where your payer or your provider needs to message you and schedule care. In this two-way SMS, this allows us to have two-way conversations with a member or a patient. So we can actually prompt a message and get a response, and we can take that information that comes back from that response in natural language, and we can develop keywords that we can respond and make sure that that person is handled with care. So whatever the response may be, we would make sure that if they needed to call a phone number, we can prompt that phone number, or we can send them to a portal with more information. So it provides a two-way, very lightweight but effective way to keep in touch with the member. And then lastly, the streaming content. So we've developed internally a very effective way to communicate in short and quick bite-sized moments. You'll see in the photo, this is known as what's called photo novellas, or I like to call it, it's like a meme. So as many of us are familiar with memes, I think they resonate typically, depending on the content, with most people. So we've taken the same approach to help those members, feel that it resonates with them, it's relevant, and that they know they have the information they know to be able to take the next best action that they have.
It's actually kind of interesting talking about this, Wendy, because I was actually watching, I think it was a couple days ago, How to Live to 100. And I think it's Dan Buettner, who's been like researching a topic for 20 years. He goes to these blue zones around the country, which I'm sure some of you know, it's where the largest number of centenarians basically live to 100 over, whatever the regular population does. And one of the main things that he had mentioned, and I kind of researched this, was having a community and people to socialize with. And I researched this in the National Institute of Aging, and the health risks of long-term isolation, it's equivalent to smoking like 15 cigarettes a day, and it can shorten a person's lifespan, for about 15 years. So I think that one thing we kind of overlook, and again, even with the younger population, a lot of them are more isolated. It's something that needs to be addressed. And of course, it also mentioned in this article that it lowers the amount of people that are actually admitted to nursing homes and of course to emergency rooms. So I think that links pretty well to this.
Yeah, great call out. All right. And then lastly, we have a use case that we have with our client Magellan Health. It was specific to social isolation, as Aram just mentioned, but we built a solution with Magellan using our SMS messaging platform and streaming educational content for a 6-week period. Down at the right-hand bottom, you'll see the overall engagement rate. So 39% of the members that were part of this plan actually engaged and 72% completed. Now, when I look at the numbers, and you probably all say the same, like, how do we get to 100 is always my question. And what we do here at mPulse is we take the information in the content that we're building and we continue to evolve it. It's not one and done. So our goal is to hit 100 internally when I think about, when we're building these. We know that's not always possible, but the second thing I always say is 39% is better than 0%, which yields no action at all. So when we think back to the first slide of 50% of the population seeks ER care, the more that we can do and put information out there, the smaller that number will become over time. And when I think back to the last 6 years, I would say only in the last 2 years of my time in healthcare, maybe 3, have we really spent going hard on emergency room deflection. So there's a lot, given the population is so large and the propensity, we have a lot of work to do, but I see us as a group of all of us here chipping away at the problem together. And that covers it.
Appreciate it, Wendy. Thank you so much. So now I'm going to kind of get into the patient journey, specifically around unnecessary, right? So the impact of unnecessary ED utilization. So when we talk about reasons for unnecessary ED visits, as Wendy mentioned, proper education comes into both avoidable and unnecessary visits. So going back to the pandemic, research shows that during the early stages of COVID-19, there was a drop in ED visits from 2.1 million to 1.2 million during that time period. We can't know without a doubt what all the reasons were, but we can make an educated assumption that a fair portion of those were minor illnesses that didn't constitute an emergency, right? There were also those who needed it though, right? Then maybe they forego care. Regardless of the reason, both need to be educated on when it's necessary to go to ED, and those who didn't need to go to the ED, with minor issues could maybe be going somewhere else to avoid those bottlenecks in operations and financial burden, which again, especially impacts those participating in value-based care. Now, at the same time, those who did need to go to the ED because of life-threatening episodes, they really should be going, right? And it's unfortunately true that there were cases like that. If we can get patients properly educated on when to use an ED versus urgent care, then that way that emergency department can really operate more efficiently for those who actually need it. And that's why patient or member education is really important, right? So giving one personal example, I got COVID 2 years ago. Now working in the healthcare technology space, I knew not to go to the ED because my symptoms were really not that bad and there was really nothing they can do for me. I know that. I just have to kind of wait it out. Other than that, one of the main reasons I don't go is what we've been kind of mentioning is really that wait time. I don't even like to wait in the grocery line. So I really don't want to wait in an ED. And the second, of course, is the cost. It's going to cost me a lot, no matter what it is, right? My fiance's mom, on the other hand, which has gone to the ED about 4 times that year, I can confirm, that she had kind of COVID symptoms and she went in for COVID, right? There was, again, nothing that they can really do about it. But that's kind of a clear picture of me not going, her going, that it's really the kind of clear way of me painting that picture of why education is important, right? In this case, I was the one that educated her right after, but it's a lot harder, of course, for any of you that's managing lives of thousands of people at a time, right? Now, again, COVID's kind of cooling down after, and we're starting to see now more ED visits. And it'll be easier to measure why people are actually going due to claims and E&M data, but we can be sure that a sizable amount of these will be unnecessary or avoidable even, right? We can also expect that there will be more ED visits during the upcoming flu season, right? That's just right around the corner, and there's usually usually always is an increase. And if COVID-19 begins to increase, which again, it seems like there is in some of the news articles that I'm seeing, there will also be an increase due to that as well, especially with more schools and offices going back to in-person. And now that points on this slide show a few of the areas that are impacted with ED overutilization. This includes much more spending by the providers and plans, including patients as well, right? You can see that an average ED visit is 12 times higher than a PCP visit and 10 times higher than an urgent care visit. That second point that you're seeing over there is related and speaks to the NYU algorithm that was developed with some edits to methodologies in this case study. Now, based on the population that was researched, 58% of all visits could have been handled in some type of primary care setting. Now, that's a big percentage, but again, it aligns closely to what we've seen from the research that we've done throughout the years. Finally, this is something that's come up more recently, I feel like in the past year or so, and that's really physician burnout, which is part of this quadruple aim for value-based care. Now, documentation is important and needs to be done, but incorrect coding is a big issue that can lead to bad quality of care and revenue loss. So spending almost 2 hours, as you're seeing on the screen, after a shift to complete documentation is a problem. And a perfect example of this is my cousin is an ER doctor in LA, and I called her a few weeks ago to check in, ask her how she's doing, and honestly to see if she can be part of this webinar to speak a little bit about it. Unfortunately, she really couldn't, and that's really related to what I just said. And she was just saying, I'm too tired. I'm just so tired. And it's really because the ER is flooded, and because of that, doctors are burned out. And of course, if a doctor's tired, can't work to their full potential, that's not good for either the patient and of course not the provider as well. So what do we do about addressing the problem? Well, to start, it's being able to engage with patients through their preferred channel in a way that relates to them. So we leverage, as kind of Wendy had mentioned earlier, behavioral science and natural language understanding to change the way patients think about health and get them to take an action to improve their health experience. We also do this at a scale and get data from our conversational AI communication. So that's again back and forth bidirectional communications, and report all those responses on an individual level. So each patient you get the responses from each patient, and then we show the total engagement rate on a population level. And finally, we take into consideration the reading level even in our solutions, right? So no program messages are above a 5th grade reading level, because we understand again that accessibility and equity are really the main foundations to a great patient experience. Now, what you're seeing above is what we call a patient journey, and if you're part of a plan, you can call it a member journey. Again, it's the same thing. Now, I'm sure anyone who has kids, telling them once to do something doesn't work. When you mentioned, it takes 8 times. Most adults I've learned, there's no difference, myself included even. So studies show that just over 1 hour, people retain less than half of newly presented information. It gets worse from there. After 1 day, it goes to 70%, and then after a week, it climbs up to 90%, and that's just an average, you know? So that's why we do multiple touch points in our programs. One message might not and probably won't be enough. So we continue to build on top of it, and we use visuals and behavioral science so the message gets across and it really sticks. Now, on top of educating patients through our programs, there's the added benefit of the trust that you're able to build with good patient experience. So this trust creates really an open line of communication, right? It helps you form a relationship, and that'll be able to close other gaps that come up, whether it's screenings, medication adherence, or anything else. Now, finally, I'll walk you through a little bit of the slide. For this program, what we have is that first step that you're seeing over there. And basically, what you're seeing is, you know, the educational piece, right? When is the right time to go to ED versus urgent care? Because again, a lot of people don't know. And that first message will go into the streaming health education content, which is that next step. So over here, you're seeing the content from our streaming health library specific to ED diversion. We have hundreds of tailored videos, whether it's expert speaking, photo novellas, animated videos, and more. And the video I'm about to play uses behavioral science to help viewers understand the differences between ED versus urgent care and the benefits to going to an urgent care instead of ED if your symptoms or issues don't require emergency medicine, right? Streaming content is one of our biggest differentiators, and it's incredibly useful in building knowledge around specific topics and has really proven to be successful in communicating that information. And the content is really highly produced, which again makes it both fun and educational for good member experience. We did mention this earlier, again, depending on your population, there's two versions to this video. One that mentions kind of a cost as a deterrent for commercial and Medicare members to avoid the ED on top of wasted time. And then one that doesn't have that cost aspect to it for let's say Medicaid members. Again, average ED cost I think is around like $5 for a visit, you know. So let me play this video for you real quick, and you can take a listen and look.
Ted and Tina are friends. They love to bike, but one day they crashed and they both got hurt. Tina went to urgent care. Ted, he went to the emergency room. In 30 minutes, Tina was talking to a doctor. Ted was sitting in the waiting room, his arm hurt. In an hour, Tina was getting x-rays. Ted was sitting in the waiting room. Some kid coughed on him. In 90 minutes, Tina was getting fitted for a sling. Ted was sitting in the waiting room. His coffee's full. In 2 hours, Tina was on her way home. Ted, still waiting. Sorry, Ted, could have gone to urgent care instead.
So again, that's a fun way of kind of relaying the information, but it's important messaging, right? And from a Harvard Business Review in 2019 article that I had, it was estimated that average emergency department wait time was more than an hour and a half to be taken into a room, and then 2.5 hours before being discharged. Patients who arrived at the ED with broken bones waited on an average of 54 minutes before receiving any type of pain medication. And the number of patients who actually leave EDs without being seen has almost doubled in those recent years. And of course, there is also the financial loss aversion piece, right? Which is including which you basically, you know, didn't see in this video, but that financial piece, when we talk about loss aversion, it's, you know, what you could potentially be losing out on. Over here, it's money and time whenever it's an ED visit. And if an ED visit is 12 times more than a PCP and an urgent care is 10 times more than a PCP, we'll be able to actually impact that portion of the population, and that'll be of major effect.
Ted.
Now here you're seeing again the continuation of it, and this is really the user experience which leverages our natural language understanding and our content. So again, whenever we're saying natural language understanding, that's actually, you know, catching spelling mistakes, or, you know, whenever someone even responds with something that isn't one of the options, let's say, we can interpret that. If it's over here, you're seeing actually it says emergency, right? It says text ER or urgent. They text emergency. We'll pick up on that. We know what the response is. And again, this is actually for phrases as well, not just single words. So this is the next step in the journey, which is a knowledge check message on top of it, right? The patient responds. After that response, we provide them with that infographic showing reasons to go to ED versus urgent care listed on the phone. And what we're doing is we're really engaging the patients and getting them involved in the conversation, right? And that really helps with that stickiness and keeping it in their minds. This is the next step, and again, I think this is a really important piece. I'm going to mention this in the next slide actually, but the next step is really a text to find urgent care locations near you, right? And we use a geolocator. Basically, again, with some of these programs, it's in network with your ACO or plan, right? You want to keep them in network. You want to reduce that leakage, right? So the geolocator is activated, and we share local urgent care clinics nearby, making it easy for them to find one of those in-network urgent cares, right? Continuing the journey, we have that telehealth or a nurse line we can add to help with overutilization. If those are options that you have, we can put them in at the end, right? This way, a patient can call in if they ever have questions before they, before they actually end up visiting an urgent care, or excuse me, an emergency department. So that calling option, again, somewhat of a telehealth, can really help with lowering the amount of ED overutilization. Now, again, this is the program that I was talking about. This is something that we're still currently even running. So it's for an ACO MSO that has value-based care agreements with major payers in Florida. On top, you're seeing actual responses from patients that were in the ED diversion program. We're seeing a 35% engagement rate with this program in the first 3, I think it's coming in close to like 4 months. It's been rolled out. Now, our expected engagement rate was around 20%. That's what we were really expecting. That's kind of the average that we see. So 35%, it's actually really high considering that this is a Medicaid population in Florida, which has some of the highest overutilization rates. If Medicaid engagement is that high, that usually means Medicare and commercial engagement can be much higher. I think our engagement rates are pretty high as far as whenever we're talking to Medicare, it's a significant higher, and then of course commercial as well. So we have multiple members that you're kind of seeing on top, texting urgent to see those nearby urgent cares that are in network. And again, that's important to avoid patient leakage and then keep an accurate medical history, right? And then our bidirectional communication is allowing patients to give responses that we can see and then report on them again in an individual level. And that gives a lot of insight, right? So again, you kind of get that dashboard to that overarching site, and you're able to see those engagement rates, and you can see even a summary, kind of SDOH information on that program manager, data including gender, average age, visitors, age bands, whatever you provide to us, it'll summarize in that dashboard overview. And based again on some of the responses, you can connect with these patients to improve their experience or get them inside to PCP. Another one that I'm seeing over there right now on the screen is I don't have a primary, right? I didn't realize I have a doctor's office. I bring my kid to the ER a lot. These are people that, again, you can reach out to. You can actually affect this change, and you're finding out this information whenever we're reporting back to you, which again can be, every week, every few days, every month, however you actually want to do it. So you can put them into a PCP assignment program after the ED one, you can put them into that one so you can follow up. Or we can do a portal adoption program if you have the portal option, so they can log in and then maybe choose a PCP, look at claims data, and be more interactive with their healthcare. Over here, here's a program we ran that's been very successful. This is actually one that was for the first 4 months, I think in 2019 for ED utilizers between May and August. You can see before outreach, the population had 18,841 ED visits. And then after incorporating our program, there was a drop of 70%, which is 5,715 visits. When taking into consideration the average cost of an ER visit in 2019, which I think was what, 1,082 down there on the bottom, and multiplying that difference, which is around 13,000, you can see that the total savings for planning consumers was a little over 14 million, and that's a big ROI again. So this is a one that's been very successful and one we again try to replicate. And this is one more use case again that I like to bring out, and it's another program that's not the ED program, but it's a PCP follow-up program, right? And it's after a patient is discharged from the ED. So again, this is really valuable because of the HEDIS FUH measure to schedule a PCP appointment within 7 days of discharge, and also important for other measures like the FMC and TMC measures. So these are all measures we can impact that can be a follow-up to the ER diversion program. So we can also follow up with other programs as well, closing gaps in care, cancer screenings, flu vaccinations, annual wellness visit, which is a big one, and more. And the ROI for this program specifically was 32 to 1. So, and you can see actually the potential impact whenever I'm going to be showing the ROI calculator actually shortly after this. We're coming close to time. Here's a poll question. Before we get to that ROI, we'd love to get one more poll question answered. Garrett, I'll have you kind of take that away.
All right. I have put it up for voting, and this is also a select all that apply. It's a how are you addressing potential upcoming ED increases for 2024? So we'll give everybody a minute. Okay, answers are still coming in, so we'll keep going with it. All right, we'll shut it down in about another 10 seconds here. All right, we're gonna close it in 5, 4, 3, 2, and 1. Here we go. All right, and I'm going to share the results now. Are you guys able to see it?
It's loading. I think. There we go. That's always good to see. Providing outreach programs. I think Wendy, again, we've been talking about this and agree with it. Those outreach programs, super important. Educational piece, super important. What we've again seen, and we have other channels of communication. We do email, we do IVR, but the SMS channel again is the one way. SMS messages, they don't go to a junk folder, right? You get that SMS message, and even my parents that are older that really are not tech savvy at all. When it comes to banking, when it comes to health, they engage with their text messages whenever it comes to plan outreach or provider outreach. So it's good to see that. So the
Okay,
ROI, yeah.
You want me to pull it down? Okay.
Yeah.
All right.
Thanks, Garrett. So over here, again, last part before questions, quick ROI model, right? So here's the ROI model we made for ED diversion. Now you can put the right data in the blue areas, which you're seeing kind of highlighted on the right side over there. But just to make it easier, we chose a number, 25,000. So again, you'll have this deck after available. You can play around with the numbers, do whatever's right. But if you take that target population of 25,000, which are high utilizers, and that's defined on the bottom over there, it's kind of really 4 visits. Now, each organization defines them differently, states define them differently, but 4 or more is a number we see pretty often. Sometimes I talk to others that have 10 as high utilizers, and some have 3. So again, we just kind of choose 4. That's something we've seen consistently. But when you're multiplying those 2 numbers, you have about 100,000, which you're seeing as a number of ED visits per year, right? Now, the average non-emergent visits nationally is about 52.7%. Again, what we're kind of seeing in general research. And that gets you, again, out of that 100,000, that's about 52,700 visits. And our impact to those amount of visits is about 50% on average. So once you do all the math and everything and multiplying that by 50%, you get about 26,350 visits that we can actually impact. And to put an average cost of ED visit, we have about $13.65 currently. So you get a monthly savings, and that's really what you're seeing on the right over there on top, and then a potential yearly savings, which is what you're seeing on the bottom side over there. And you can see that's actually, again, very impactful. For Medicare, the annual visits, again, this is the Medicaid model. There's a Medicare model that we have. It's slightly lower. It's around 47%. So again, you can play around with that if you're in Medicare, which is almost equally impactful though, right? And you're not only benefiting from the BBC financial incentives, but you're also creating better operational efficiencies for your organization and then lowering ED physician burnout. Questions? Garrett, I think I'll pass that over to you to take over real quick.
Okay, and I will come back on camera for that. All right, yeah, we do have some questions that came in. If you have a question now that you would like to ask, go ahead and submit it using your question module or your little module there. There's a place for questions. We're going to get to as many as we can. We don't have a whole lot of time, but if we don't get to yours, don't worry. Someone will reach out via email afterwards. Okay, diving right in here, first question is, can you tell us more about consent? How do patients opt in to the programs and how are they authenticated?
Yeah, so that's a question that comes up from time to time. Again, it's an important one. So in the TCPA, which is the Telephone Consumer Protection Act, there's a specific healthcare carve out, which says if a healthcare organization basically make contact, if they have contact information, which is something called implied consent, they're allowed to contact them about their health as long as it's not marketing or billing information. So there's a couple of ways we kind of handle this. So when it comes to HIPAA information, when we look at this, do we want to do an opt-in? Meaning I'm going to send a text to Wendy and say, hey, this is Path Health reaching out. I have some information that's really specific to your health. So text back yes if you want to opt in. And if Wendy texts back yes, that's the green light for you to continue to text her. And that's the opt-in strategy. We also use the opt-out strategy, which is basically saying, Wendy, I'm going to text you until you tell me to stop. And that stop language is the message, is in all the messaging that we really send. So it really depends on what your organization is comfortable with, but we do both of them. We obviously have the most success with the opt-out option, and that's really what a lot of our clients choose. And then from really a regulatory standpoint, a risk standpoint, we can do things differently as well. For example, when it comes to really medication adherence, we might put the first 3 letters of a medication. Like if you have a refill, you put the first 3 letters. If you want to see the whole prescription, we might have some other type of authentication, right? It's like a date of birth or maybe a zip code or something like that. So it really depends, again, for the client. But there's also programs that we have, for example, annual wellness visits for Medicare or preventative visits for Medicaid, flu vaccinations. Everyone is eligible for that. So then there really isn't any issue with that and sending them out. But again, we work very closely and really it's just adhere to your guidelines, and then we kind of give basically the advice that and what we've seen and the input. We'll give you some input on the programs that we've run for clients and what we've seen as successful and what they've done.
And I'll just throw in one thing around too. So from the opt-in piece, it can even go one step, a layer deeper, where a payer may not have consent from a member at all to actually SMS them. So we handle that through email. So given we're an omnichannel solution company, we can actually use our email program to, number one, kickstart the program, but also use that as a way to engage people to opt into SMS so that we can reach them faster. So we use that and also our two-factor authentication to ensure our information is sound and secure. So with those 2 additional pieces, we pretty much cover the landscape of the enablement of getting people into engagement mode.
Great. Next question, and again, we don't have a whole lot of time, but next question is, do you have any stats that state how many people with Medicaid have smartphones? We have seen data that a large number of them have mobile phones, but a very low number are smartphones. Just wanted to validate if that data is accurate.
Yeah, so I mean, I can speak to some of the areas. For example, so I was mentioning very large provider on the West Coast, and they have data as far as kind of what a percentage of their Medicaid population, which in this case, again, California, this was 200,000 of their population. And she had mentioned to me that a large amount of, again, homeless population, Medicaid population, whatever, they actually do have smartphones. It's really engaging with them and getting them to actually respond. Specific stats around it, I'd have to go back and look to see how many, but general statistics just overall is that I think it's now 95%, not specific to Medicaid members, just generally have a smartphone, have a phone, and 85% of those are actually smartphones. Specific to the Medicaid population, we'd have to dig a little bit deeper, but I'm sure we can get that information over to you.
Right. To capitalize on that, we just did an exercise to validate that, what Aram just said. The second piece of it is around the plans. So there's the pay-as-you-go phones that are smartphones. Where that comes into play, depending on the population, is how long our segments are. So when we think about cost to deliver an SMS message, might cost somebody more if they're on a pay-as-you-go phone versus somebody kind of unlimited. So, and also video. So we really pay attention to the consumer we're targeting based on those criteria and the personas that we target. So really good question, whoever asked it. It's definitely what we pay attention to when we build our programs.
Great. So we have time for one more, and if it's possible to do a quick answer to this one, that would be That'd be great. This one is, do you have any results to share about how well the text campaigns have worked to divert people from the EDs for non-emergencies?
For non-emergencies specifically, I think we do have some program results that I can look into, but I'd have to probably speak to the team and get specific results for you. But I think we can do that. Yeah, and we can send it
We have
over.
a lot of non-ED campaigns that we send out, so it's pretty vast. It can be anywhere from your diabetes campaigns to dental, for that matter. So we've got a plethora of data on that front.
Yeah, that's a good point. That's a good point. Well, unfortunately, everybody, we are out of time. We did have a few more questions that came in. And if you do have a question, please do ask it right now. Someone will get back to you through email later. So go ahead and ask your question. Real quick, I think Aram is going to speak to Activate 2023, and then we'll close it out.
Yeah, just wanted to quickly mention again, this is our annual Activate 2023 conference. It's coming up this month, again, September on the 27th and 28th. All attendees to this webinar actually, again, get a free registration. We've been doing that with BBC. There will be great discussions around improving quality, consumer experience, and health equity. You'll see a lot more than whatever we were able to present on, and get, again, really good education. You can visit our website for more information, or again, reach out to me via email, and I can even do the registration for you. So we'd love to be able to see you guys there, and hopefully we'll.
Great, and I'll send a link out with a little thank you note where I'll also send you the recording and where you can download the slides from today's presentation, but there'll be a link to Activate if you want to find out more about that. Finally, I wanted to thank our speakers today. Thank you guys so much. This is really informative. Obviously, there's a lot here. And so appreciate you guys covering in the detail that you did. As we close out, I wanted to encourage you all to head over to vbcexhibithall.com. And there you will be able to actually visit the mPulse mobile virtual exhibit booth. And here's a place that there's a lot of different resources. You can read up on them, just really educate yourself on what they're doing in the space. And that way, and then of course, reach out to them directly through that. And so I definitely encourage you to take advantage of that. We also have a lot of other great resources there in our library, our archive library. You'll be able to find the webinar from today, along with a lot of other webinars and related articles that are going to be helpful for your search. So I hope that you join us at vbcexhibithall.com. And then finally, if you'd like to reach out to our speakers today, their information is here on the screen. And again, that will be included in the slides that I send out. So I encourage you to reach out to them directly if you have any questions or would like an RFP or a proposal. And then feel free also to reach out to me. I'm happy to facilitate an introduction if you'd rather do it that way. But either way, really appreciate everyone joining today. Thank you so much for your time. I hope you have a wonderful rest of your day, and we'll see you on the next webinar. Thank you so much.
Appreciate it. Thank you.
Bye-bye.